So a lot of people who have thought about heart failure epidemiology, taken a class or lecture, hear about the Framingham Heart Study. So this is Framingham. It's near my old home in Boston. It is a small city outside of Boston, and it was selected to, in the 1940s for the first really landmark study of cardiovascular epidemiology for a couple of reasons. One, it was close to the researchers at Boston University and at Harvard who were conducting the study. It was also a place where there had been research ongoing. So there was a tuberculosis study that was done in Framingham prior to the Framingham Heart Study, and so there was buy-in from the local population and from the local doctors to do this kind of research. So in 1948 to 1952, the Framingham Heart Study investigators recruited 5,200 men and women, middle or early to middle age, and they were re-examined every 2 years. And the Framingham Heart Study is still ongoing. Very few of the original participants are still enrolled, but now their children and their grandchildren are involved. And they've recorded cardiovascular events ever since the 1940s. And Framingham was not the first study to look at heart failure. There had been a number of studies prior to this, but what Framingham really did was look at heart failure in a systematic way. So clinicians in the room know that diagnosing heart failure is not necessarily straightforward, right? Most of these patients come in with a lot of issues and a lot of problems, and so trying to decide whether, with the patient sitting in front of you, does this person have heart failure, or is heart failure the major reason that they're here versus something else like COPD, is a challenge, let alone when someone like me comes along as a researcher and is trying to then collect this data. It just compounds the issue and makes it very challenging. So what Framingham did was they came up with these criteria for the diagnosis of heart failure. You might not like these criteria. People have gone back and forth about whether this is really a good way to define heart failure, but it is at least a standard, and this is a standard that was set for a number of years. So in their first report on heart failure from Framingham, they identified the risk factors that we're still really familiar with. Hypertension and hypertensive heart disease, older age, coronary heart disease and MI, male sex, and rheumatic heart disease. So that one's a little bit of a little different from what we'd see today. And they showed that there was really poor prognosis. So 5-year mortality was 42% in women and 62% in men. So then, in the 1990s, there was an update of this landmark report. This is now including the original Framingham participants and their children. And again, you can see that age is a major risk factor for heart failure. Most people with heart failure are in their 70s and 80s. And you see the same sorts of risk factors that you saw in the initial report. So things like hypertension, diabetes, and in this case they've added, instead of hypertensive heart disease, really thinking about left ventricular hypertrophy. So the question is, okay, Framingham did this. They did it. They have this landmark paper in 1971. They have another one in 1993. Why are we still looking at risk factors for heart failure? Well, a lot has changed. So we have differences in the diagnosis and treatment of heart failure between now and then. We have differences in the diagnosis and treatment of our risk factors for heart failure, the prevalence of those risk factors, and additionally, who is included in epidemiologic research. So I swear I didn't put George up to his comment about heart failure being a process, but one of the things that has changed is really conceptualizing heart failure as a process and as a slow development. So thank you, George, I appreciate that. So this is the stages of heart failure that were conceptualized by the American Heart Association. So you have stage A and B, which are really not heart failure in any clinical sense. They are high risk of heart failure with and without structural heart disease. Stage C heart failure is more of sort of what we think of as being an incident heart failure event. And then stage D would be the refractory heart failure for the people who are getting the LVADs, if you were here for the clinical session prior to this one. We've also now have BNP as a biomarker that helps us differentiate between heart failure and things that are not heart failure, but might look like it. there is a greater recognition of heart failure with preserved ejection fraction. So, when looking at the initial Framingham criteria, you don't actually have ejection fraction on that list of criteria. But in between sort of that 1971 report and then probably the late 1990s, early 2000s, there was a really more of a focus on reduced ejection fraction heart failure. And then, looking at those echo parameters, and then, coming back in, looking at, okay, yes, heart failure with preserved ejection fraction really is a major component of the heart failure that is seen clinically. Additionally, there are a number of new treatments, or new-ish treatments, for heart failure with reduced ejection fraction, including beta blockers and then the most recent neprilysin inhibitors. Unfortunately, these have not shown benefit for patients with preserved ejection fraction heart failure. We also are not talking about risk factors in the same way we were in the 70s or even in the 90s. So in the initial Framingham reports, the investigators defined hypertension as systolic blood pressure greater than 160/95. And the first clinical guidelines about the treatment of hypertension, we're talking about treatment when diastolic blood pressure was over 100. Right? So this is not what we're talking about when we're talking about heart failure or when we're talking about hypertension in the current era. So the most recent American Heart Association, American College of Cardiology definitions have hypertension as greater than 130/80. So this is a very different situation. In the original Framingham study, about 10% of the population had systolic blood pressure above about 190. So, these would be people who today we would probably be sending to the hospital right away. And these are people who are just walking around. So it's a very different era. We have very different prevalence of risk factors. So rheumatic heart disease now is quite rare, at least in the United States. From the original Framingham report, 20% of their heart failure patients had rheumatic heart disease prior to their heart failure event. So that's a very different parameter. We also have emergence of new risk factors like HIV, and I think that's something that is an area where there's a lot of interesting work going on. We have also really rethought who is included in our medical research and in our epidemiologic research. So many of the early studies included very homogeneous white populations. In Framingham, the population is entirely white. The initial investigators justified including Framingham in part because of the diversity of the population. But when they were talking about diversity, it's not like we're talking about diversity today, because they're talking about people who are of Italian American, German American, Quebecois. It's not the same as what the U.S. looks like today or what our medical research looks like today. Current research policies really prioritize inclusion of minority populations in meaningful ways. What hasn't changed? Well, hypertension is still one of the major risk factors for heart failure. And the prognosis is still really bad. So the most recent American Heart Association, American College of Statistics update quoted the 5-year mortality as 42%. So that really hasn't budged much since the 1950s and 60s. So I'm going to be talking about some work that Matt Medford, who's a graduate student working with me, has been working on in the REGARD study. And thinking about why are we still looking at hypertension? Well, yes, we know hypertension causes heart failure, but there are a bunch of questions that are still unanswered. So in particular, does the relationship between hypertension and heart failure vary by race? That might sound a little strange. Why would you expect it to? Well, and the reason that we might expect it to is because there is actually pretty good evidence that hypertension is a stronger risk factor for stroke and for some kidney outcomes in Black individuals compared to white individuals. So, we thought that this might also be there in heart failure as well. There have been a couple of studies looking at hypertension with heart failure with preserved versus reduced ejection fraction, but not many, and they've been not very consistent. Additionally, when we think about who are the people with hypertension currently in the U.S., most of them are treated, and a lot of them do have good control of their blood pressure. So we want to know to what extent does that good blood pressure control mitigate the risk of heart failure? And finally, duration of heart failure, duration of hypertension, and how does that affect risk of heart failure? So for the research I'm going to show you, this is based on the REGARD study, for which George Howard, who is our moderator, is the principal investigator. REGARD's recruited over 30,000 individuals from across the continental US. You can see here the map of where they're located. And these individuals were recruited between 2003 and 2007. And there's oversampling of individuals in the southeastern United States as well as Black individuals. So this is a much different cohort, much different map than our map of Framingham, which is a small city in the northeast of the US. So participants were 45 years of age and older at baseline, and they completed a telephone interview as well as an in-home examination. And they've been followed continuously through telephone interviews as well as some other more administrative techniques to try and identify heart failure hospitalizations. And these have been adjudicated through 2015 at this point. We're still working to adjudicate more recent events. In this cohort, unlike a lot of the prior cohorts that have tried to look at heart failure, we do have BNP on almost everybody who's hospitalized. And that's really, I think, been a boon in terms of adjudicating these events, trying to make sure that what we're looking at really is heart failure. And several of the adjudicators are also here today, so that's great. And we also have ejection fraction for the vast majority of these individuals. So they're, on average, about 65 at baseline. A little more than half female. The prevalence of hypertension in this population is really high, but this is not terribly different than what you would see in the US population, particularly with the sort of what is normal creeping downwards. We see that, that most participants actually do have hypertension, but when we look at what is their blood pressure, even among the hypertensive participants, mean blood pressure was 132/79, right? So these are reasonably well controlled. And about 4% of the population had incident heart failure over this time period. When we look at, so what are the results? What do we see? These graphs are hazard ratio graphs. So you can interpret the dot as the ratio of the risk in the group with hypertension as compared to the risk in the group without. And we've stratified our results based on race. So you have the white participants and the Black participants. For both groups, the hazard ratio is greater than 2. So hypertensive individuals have a greater than 2-fold higher risk of heart failure than people without hypertension. It looks like maybe it's slightly, hypertension is a slightly stronger association with heart failure among the Black participants, but that was not statistically significant. Next, we looked at half-PAF and half-REF. And for both white and Black participants, there are slightly stronger associations with half-PAF than half-REF, so preserved versus reduced ejection fraction. But again, the differences were not statistically significant, so hypertension was associated with both. When we looked at duration, we see that the highest risk is among those who have long duration hypertension, so greater than 10 years. But there's still a substantially increased risk among those with shorter duration hypertension, so less than 10 years. And when we looked at less than 5 years, we saw almost exactly the same pattern. And finally, when you look at hypertension control, you see that, yes, people with uncontrolled hypertension have very high risk of heart failure, but the risk of heart failure among people who have controlled hypertension is still substantially elevated compared to those without hypertension. So in summary, we saw that hypertension was associated with increased risk of heart failure, which was not surprising. We've known that for a long time, but also similarly associated with half-PAF and half-REF, that there was no statistically significant difference between black and white participants and how hypertension was operating, that the highest risk of heart failure was with uncontrolled and long duration of heart failure, but there's still a substantial elevation in the risk of heart failure, even if the hypertension is of short duration or is well controlled. So really what I think the message of this study is that both primordial prevention, so preventing people from developing the risk factors in the first place, and therapeutic management of hypertension are important in reducing risk of heart failure. So yes, we can treat hypertension, and yes, we should treat hypertension, but it doesn't bring people back to being non-hypertensive. So thinking about where we started and where we are now, Framingham and other landmark studies really established the major risk factors for heart failure. However, the changes in the diagnosis and treatment of both heart failure and heart failure risk factors mean that the older results really might not apply to the contemporary populations. And the contemporary studies can really provide nuance and expand the diversity of who is included in these populations. I'd like to thank the co-authors and contributors to this study, as well as the funding for the study, and in particular Matt Medford, who has done the vast majority of the original data that I show you today.